And welcome. Thank you so very much for joining us today. It's really great to see you all here. My name is Lona Lordson-Berger. I work with Action Canada for Sexual Health and Rights, and it's my absolute pleasure to be moderating this webinar on access for all, homelessness and migration status as barriers to abortion in Canada. I first want to say a huge thank you to our panelists for sharing their time and knowledge. We're very, very grateful, and I think all looking forward to this conversation. And before we get started, just a couple of housekeeping items. So we have interpretation from English to both Spanish and French. We'll also put this in the chat. You can access that using the globe icon at the bottom of your Zoom screen. You can also access auto-generated captions by clicking on the CC button at the bottom of your screen. Throughout the event, you could submit questions using the Q&A function. And we do ask that you please direct questions to the Q&A and not the chat, which we won't be monitoring quite as closely. And so today we'll be sharing learnings from a report that we authored together on abortion access barriers with a focus on migration status and housing. We'll dig a little bit deeper than the report could, and we'll be exploring the interconnectedness of rights and the relationship between abortion access, health equity, and systemic oppression. We'll close by sharing our recommendations and visions for strengthened access to abortion care for all people in Canada. So I'll give everyone a chance to introduce themselves and a little bit about their work shortly, but this conversation will be between my colleague, Coral Maloney, who's an Access Line Navigator here at Action Canada, Dr. Evelyn Encalada Grez, who's an Assistant Professor of Labor Studies at Simon Fraser University and also works with Justice for Migrant Workers, and Mary Vaccaro, who's a faculty member at McMaster University and also works with YWCA Hamilton, in particular around the themes of pregnancy and homelessness. And so just to give a little bit more context, and we can jump to the next slide about why we're gathering here today. This conversation is an extension of a report that we submitted to Canada's Universal Periodic Review, or UPR. So we won't get into the details of this, but briefly, the UPR is a process of the United Nations Human Rights Council, where each country is reviewed by other countries on its entire human rights record every 4.5 years. So Canada's review is coming up this November. As part of this process, civil society can submit reports to be taken into consideration in the review, which we did with several other partners, including the Barbara Schleifer Commemorative Clinic and the Sexual Rights Initiative in Geneva. So we'll share a link in the chat also to some of our work around this and the report if you're interested in digging a little bit deeper. And you can also expect to see some more around this in the coming months. And so this report has the core aim of shaping recommendations that UN member states make to the country being reviewed, which is in this case, Canada. Our report focused on inequities in abortion access, looking at the overlapping and interconnected factors that complicate access, and focused on migration status and houselessness as two really acute barriers where we see people struggling to access care. So the process of engagement with the UPR is important and useful for a number of reasons. Namely, it situates these issues within a human rights framework, understanding this constellation of rights as interconnected, and making very clear the links between sexual and reproductive health and rights, or SRHR, and housing rights, labor rights, migrant justice, and so on. It also situates the protection and fulfillment of these rights as an obligation of the Government of Canada and demands accountability towards this. Still, though, there's some limitations around this type of reporting and this process. So for one thing, the word count is quite short. The audience tends to be busy diplomats with limited knowledge of the context. And we also need to focus strategically on influencing recommendations. So it's not necessarily the most accessible or interesting format for public audiences, which is why we wanted to talk also in this space. So these factors pose a little bit of a limit to the nuance and depth of this analysis that we could bring forward. But as we were writing, there were really so many interesting reflections that kept coming up and that didn't necessarily make it into the final text. So I think we're very excited to be able to share some of the key learnings from the report and our recommendations, but also even more excited to dive a little bit deeper into what we really found interesting within this content. So before we jump back into looking at the access issues, we wanted to return to this idea of the connections to land and territory. We really see this as being sort of at the center of everything as we were exploring these themes. And so I'll pass it on to my colleague Coral to share a little bit of framing around this.
Thanks, Lona. I'm so glad to be here with all of you today. I think we really wanted to just highlight the fact that, when we talk about land acknowledgements, when those are done, they are more and more frequently being done in cursory ways, and we're seeing that as we learn about how to respond to colonialism. And what I wanted to share today, in just reflecting on how we make these connections, and just to encourage us to all keep these things in mind while we talk about some of the content, are a couple of things. One is just that I really encourage everyone to take care of your hearts and who you are while we talk about these topics, because we're all interested in these topics and here because we care and because we know how necessary it is to do this work. And so that can also, of course, impact us in lots of ways. So I encourage us to acknowledge those impacts and take care of ourselves while they happen. And I think the same needs to be said for how we treat the land. So we are impacting the land all the time in the way we live, in the way we extract resources. We as like the human species, but more specifically, the powerful folks that are benefiting off of the violent extraction that happens. So, I want to just sort of share those reflections with all of us, to think about how the disconnection from land and the genocidal policies that really sort of encompass what colonialism is, are causing so many of the things that we are talking about today. And this is something that many of you know, potentially from lived experience yourselves. And so I raise that so that we're not forgetting how the discussion around abortion access connects to all the other pieces that are connected around rights access, especially when we're talking in the context of the UPR and talking about human rights. We need to also be thinking about how these pieces are all connected. And so just to name that, we're also talking about things like forced sterilization. We're talking about family surveillance. We're talking about the process of family surveillance and family policing that leads to policies such as birth alerts, which in most places are currently officially removed, but still actually happening in practice. And so we keep these things in mind while we talk about what happens with abortion access, because we can't in good faith, I believe, sort of move forward with one piece of this and forget all of the things that are interconnected. So when we think about how colonialism causes a disconnection from land, we know that the impacts of that are not simple. They are very far-reaching, they're intergenerational, they are massive. And when they intersect with all sorts of different violent policies, prohibitive policies, barrier-creating policies, that all of those add up to all of the negative health outcomes, the negative social outcomes that we see, and prevent basic rights access and basic sovereignty. So we just, there's lots of ways to talk about these things, of course, and we will be doing that today together. And I know that the attendants and all of you are here to have that conversation with us. So it's not so much as sort of teaching about that, but just reminding us that all of these things are connected, and we want to keep those at the forefront while we talk about how all of this fits within the context of colonialism in the place where we host this webinar, as well as around the world.
Thank you so very much, Coral. That was so beautifully put and an important reminder, and I think really positions us well to be able to continue weaving our understanding of it in different ways throughout our conversations today. I'd like to now sort of set the stage a little bit around abortion access in particular. So we know that abortion is a common, essential, and decriminalized healthcare procedure in Canada. We all have the right to access abortion care, but we also know that many people struggle to, and that some ultimately are unable to access care. And of course, we know that these barriers don't fall equally. Here we have just a little graphic that visualizes some of the many things that can inhibit access. So noting that this is conceptual and not data-driven, but it gives us a sense of some of the things that we don't always think about, like organizing childcare or transportation, taking time off work, privacy. and also noting that these barriers are felt especially acutely by those who experience multiple and intersecting marginalization. So as we'll hear from our panelists, we see this with people experiencing homelessness or with precarious migration status. But this is also hugely magnified when we add on other layers, when people also live with disabilities, are living with HIV, people who use drugs, sex workers, and those who experience criminalization otherwise or the threat thereof. And so let's jump a little bit deeper into how and where we see the right to access abortion being violated. And I'd ask that you each just give us a few words to introduce yourselves and speak a little bit about your experience before we jump into the main issues. And we'll start with you, Coral, to give sort of some general context to the landscape, and then pass it along to Evelyn and Mary. Thank you.
Me again. Thanks, Lona. So many of the pieces that Lona has just outlined are things that I see in my work regularly. So with Action Canada for Sexual Health and Rights, my role is as an access line navigator, and I work with a program that supports. We do a couple of different things. One is a toll-free phone line that answers questions around sexual and reproductive health. And the other piece is administering an emergency fund for people to access abortion care. And so I'll potentially just leave it there, but just to say that kind of the pieces that Lona has just outlined are ones that we encounter very regularly in our work administering that fund. And we'll get into more details about why that fund is even needed and what that means overall. Thank you.
Thank you, Coral. Evelyn, we'll pass it your way now.
Okay, well, first of all, good morning from the West Coast, everybody. Well, it's morning over here. And well, in my work, I'm a co-founder, one of the co-founders of Justice for Migrant Workers. I'm an organizer. I've been working with migrant farm workers for over 20 years now. And I focus primarily as well around issues of gender and how gender is a catalyst for intensifying vulnerabilities among migrant workers who work in the most dangerous and basically unseen or unrecognized industry or tasks within the agricultural industry. And now in my position as a labor studies professor, I attempt to make the connection with migration status and work with all these other intersections, as Coral was speaking, including sexuality. The way that workers migrate affects their intimate lives, their health, and of course, their reproductive rights. Thank you.
Thank you, Evelyn. Mary?
Hi there, and thank you so much for having me today. My name is Mary. My pronouns are she, her. I'm a faculty member in the School of Social Work, but also do a lot of research and evaluation with YWCA Hamilton. And it was during the pandemic that the YWCA Hamilton became focused on the unique needs of people experiencing pregnancy and homelessness, because there was a visible increase happening in the community. And so from this point on, we've been able to sort of enhance some supports that support people with exercising their reproductive choice and reproductive rights. And I'm looking forward to talking a little bit more about that later.
Excellent. Thank you all so much. And before we jump into sort of looking at more of the nuance of things, would you like to give us just a very sort of brief overview of what we see in terms of access issues? What are the factors that mean folks struggle to access abortion care? And maybe in the same order, we can go Coral, Evelyn, Mary.
So we've kind of talked about how these things can intersect with one another. And I think that that's something that, you know, everybody knows we need to think about that, but it's something to highlight because when the factors intersect with one another, it's not just like, you know, okay, you're dealing with two things that make it hard, make a task hard. You're dealing with the impact of those two things combining to one another. It's often an exponential impact. So just to kind of frame what I'm about to say with that, I would say that a large number of the access issues that we see are immigration status or lack of health insurance status. So what we see happening for folks who are asylum seekers, who are migrant workers, who are international students, They may have been folks who have come on any kind of a visa that has expired, and they are living in Canada. What we see for folks in this kind of scenario is a very precarious status that doesn't allow them to access healthcare. So this comes as a shock for a lot of people who understand Canada to have a universal healthcare system, and this is simply not true for people in this who don't have citizenship status that allows them to access the care. And what we see very frequently is, in fact, hospital bills or clinic bills for care that people have sought for abortion care that are actually they're a multiplied amount higher than the normal amount that would be billed for someone who did have that healthcare access. So they are billed under a tourist rate, usually like 2.5, 3 times, it varies, but it's an exponential amount compared to what would be charged for somebody who has that healthcare status. So that's a really, really huge one that I want to highlight because there is no category differentiating between someone in those groups that I had mentioned from somebody who is a wealthy tourist who, is traveling and wants to seek care, because they're choosing to, or because they are on a trip. So there's no difference between those groups from a billing perspective within the hospital system, which is a massive barrier. And then I've kind of done a deep dive into that a little bit just now, but there are many, many other ones. Abortion stigma is a very, very big access barrier, whether that's a person not being able to access abortion because they don't have anyone around them who is able to support them to access the care. They don't feel safe sharing that information. Maybe they're in an intimate partner violence context, or maybe not, and they just have a lot of social pressure around them. They may not be able to take time off work to actually seek care or to travel to seek care. I'm going to avoid making a whole a whole webinar just about the access issues, but we could certainly talk about them for days. And they include other things like, not having childcare, not having ability to take the time off work, like I'd said, including for recovery time, including for travel time, because where the abortion services are located are almost all in urban centers close to the US border. There are very rare services in rural areas, and even in an urban center, it can be very, very hard to access. So those are just a few, but there are some really significant ones that don't often get talked about when we think of abortion as sort of a normal healthcare process that happens in Canada, that is a normal procedure everyone has the right to. And then we start to run into what that reality actually looks like when people try to seek care.
Thank you so much, Coral. I think that leads really well into Evelyn adding some more context and detail.
Yes, and I wanted to take a dive into, the myth of Canada. There's so many myths in Canada. One of them is that we have universal healthcare. And we know that that's not true in many respects, but when it comes to abortion access, yes, for instance, the group of people that I work with, they are documented workers that as soon as they get onto a plane to come to Canada and work in agriculture, they have all their paperwork at hand. And after 3 months, they usually are able to get the provincial healthcare insurance. So then there's like that 3-month window where anything can happen and they're basically left on their own. But then if we think about in the best case where their insurance is supposed to cover all of their medical expenses, what we see is this power imbalance and this coercion. So even though migrant workers, the ones that I'm talking about, they have like documented permission to work, they're still considered precarious migrants. And when we talk about precarious migration, we're talking about people who are being coerced, people who have to basically be bound to one employer. And this one employer could have all this power over you as migrant workers. So if anybody can here in the background show this image that I was able to document over the years as I was supporting migrant workers, and at any point, but it just basically shows the type of coercion and policing that a lot of employers undertake. So here we see that this one employer went out of their way to have the sign made outside of a portable that was being used as a housing unit for migrant women. And so in a context like this, where your body is being surveilled, where your sexuality is being controlled, and where those who have gotten pregnant and when their employers have found out have been sent back to their home countries, it's not a very safe environment. It's not a supportive environment to get support for any healthcare needs. For instance, migrant workers, if they are injured, they will try their best to still work anyway. So when migrant workers get pregnant without wanting to be pregnant, they're basically left on their own. And then the other major issue is the rural location and how all of these services and a lot of these services are basically focused on the urban sector. So I studied international development, and we talked about how in the global south, there is an urban bias. Well, we have an urban bias, of course, here in the global north as well. And so those who become pregnant, if they don't have the right networks outside of the community, they're basically left on their own. And then they have to deal with all of that trauma of carrying a pregnancy that they are not ready for, that they don't want to. And so that creates like a ripple effects in their whole entire family. And also the language issue, right? There is no information in the languages that workers speak, but even if workers speak English, they don't have access. They don't have also the freedom to basically say, I'm going to take a day off, because you have to, since I said they're beholden to their employers, they have to account for themselves of why is it that they are missing work when they live in the property of employers, right? And so they don't have freedom of movement. And, you know, the times that I've had to do this work, it's almost like organizing like a heist, like going undercover. And, you know, when I'm in those situations, I still like get shocked, although I'm not shocked, that I feel like I'm engaged in a crime or something to help migrant workers access the healthcare that they actually need. So there's a range of factors. So even though workers are supposed to get all this healthcare in practice, like in print, and then their practice is something completely different. So there's this blind spot as well with what really happens to migrant workers, those that produce the food that we consume, those that were called essential workers. They go through a whole range of obstacles, and accessing abortion is one of them.
Thank you so much, Evelyn. I think that really adds detail to also what we heard from Coral. And if I recall correctly, I think it's something like 45% of those who accessed our emergency fund last year were uninsured, many of those on the basis of migration status, which I think just speaks to sort of the scope of and magnitude of how we see this coming in as a barrier. Mary, we'll pass it to you.
Thank you. So people who experience homelessness face, unique barriers to accessing abortion. And this is really a direct result of not having housing, not having a safe place to rest, and having such limited economic and material resources. In our work, we're also seeing that many folks don't find out they're pregnant until later on in their pregnancy. We know that experiencing homelessness, lack of sleep, improper nutrition can lead to an irregular menstrual cycle. So we know that people aren't finding out until much later, often leaving the only option being surgical abortion. And then, in order to access a surgical abortion, you need to travel. Oftentimes you need to have somewhere safe to rest and recover, both of which pose real barriers to making this happen. We also know that, many people that we're supporting at the YWCA don't have a general practitioner or even a trusted healthcare provider in their circle that they may feel comfortable to go to get that referral, or to have one person to support them to navigate the process. Many people don't have proper identification or a health card, and of course not having access to a reliable working phone where they can make calls and take private voicemails presents another barrier around the ability to communicate privately with abortion care providers. And while medical abortion can be a safe option, people living outside, people staying in shelter, people staying in drop-in spaces really would face barriers to making this happen. They don't have a safe, private place to rest in order to have that procedure, even if they were to find out early along in their pregnancy where this could be an option. So there's just a few of the barriers that come to mind.
Thank you so much. I think that really gives an excellent overview collectively of many of the sort of principal barriers that we see and how they overlap with one another also. Now that we sort of have a sense of that more general landscape, I'd like to delve a little bit deeper and more specifically into how we see ongoing colonialism and systemic racism shaping abortion access and many other aspects of sexual and reproductive health and rights in Canada. So we've touched on this sort of a little bit, but Mary, would you like to continue building on that?
Yeah, so when we think about colonialism and systemic racism in Canada, I really appreciated the way Coral framed it at the beginning, reminding us really that colonization causes a disconnection from the land, and the impacts of this are far-reaching, and that they intersect with violent and prohibitive policies. And we see these negative health and social outcomes because people don't have access to their basic rights. The health and social systems that we're asking people to navigate are built on colonial and white supremacist legacies. And we know that impacts the way people access healthcare. We also know that colonization and systemic racism has a negative impact on people who decide to carry their pregnancies to term. And that this often means that there's poor outcomes both for birthing people and for their infants. And I think it can't be stressed enough that, family surveillance, the overrepresentation of folks involved with child welfare system prevents people from even wanting to disclose a pregnancy in the first place. That fear around, although birth alerts have been canceled, that fear around the surveillance still exists. And so we may see people not seeking prenatal care at all because of that fear. And this is all connected to colonization and the way systemic racism impacts the systems that we're asking folks to navigate.
Thank you very much, Mary. Evelyn, we'll pass it your way.
Oh, there's so much to say, and I hope I do justice to 500 years of colonization. There's just so many layers, but this is a really critical question because the migrant workers that I'm talking about are from the global south. They are racialized. They are subjected to the worst working conditions. They cannot say no. And the fact that they are here and the conditions in which they are here, where they're tied to one employer and don't have much leverage over their employer, if they get their employer, for instance, could dismiss them. They could be fired from their jobs at whim without any recourse, and that means that they have to leave. So they get basically deported and sent back without any recourse, right? And so it also challenges another myth about Canada. We've been told that after the 60s, Canada has changed their immigration system to be based on the point system. So it's no longer race-based. But when we look at who occupies the temporary foreign worker programs and the bottom rungs of that program, they are people from the global south. And so when we look at the case of Mexico, for instance, a lot of the Mexican workers that I work with have been impacted in a very tangible way by the NAFTA agreement that now has turned into CUSMA. But during that time, and the restructuring during that time, 80s and 90s, a lot of small farmers lost their livelihoods. So that pushed them off the land. And they had to work in the north, either undocumented in the United States or documented through other temporary foreign worker programs there or to Canada. So we see that Canada has a role of displacing people from their livelihoods and their own land, and then coming here and having their labor extracted. When we think about Guatemala, for instance, a lot of the workers from Guatemala are indigenous, they're Mayan. And in Guatemala, there's a lot of Canadian mining corporations that have committed horrible human rights violations. And so Canada, maybe it's Canada doesn't have like the reputation as the United States, where they've interfered in foreign governments and have gone abroad to create all of this destruction. But what Canada is really good at is bringing people here and then using their bodies, extracting from their bodies. So they're not necessarily out and colonizing the rest of the world, but Canada is bringing certain peoples whose lives are not valued in the same way as citizens, primarily white citizens. And so we see that the lack of abortion access is a symptom of this racism that still exists in the country, of who basically is allowed to die or not die, which is basically the power of the government, right, of the state. And in justicia, we always say too that it's not an oversight, like it's not that the system is not working well. The system is working really well to dispose of people and to not care about people. And with the temporary foreign worker programs and migrant labor, basically people are not seen as people, they're seen as machines. So yeah, so that's the way that I connect to colonialism. It's, yeah, we can talk about it a lot, but I think it's important to have these, to make these connections with one another and give like language to what we see, because it's the same processes happening and affecting a whole range of populations.
Absolutely. I think, yeah, recognizing there's only really an opportunity to scratch the very, very surface of this in this space. But also recognizing that this gives way to like such a multitude of very different experiences, but that there's sort of a common thread that we've seen in different contributions and in other work that surrounds this around dispossession of land, displacement, sort of enforced dependency, both in terms of Canada's colonial history and ongoing sort of global North, global South dynamics. Coral, would you like to reflect or build on this?
Well, I mean, it's been very well described and articulated, and yeah, I'm just grateful for all of the pieces that we're bringing up today. I think, you know, what you're saying, Evelyn, about you know, bodies being treated as machines and people not being treated as people, essentially, just makes me think about like the myth again of choice, like this myth of reproductive choice and access. And Mary, you touched on that also, speaking about, you know, what people can see in terms of their own sovereignty around their reproductive decision making. And so I would just say that I think I'll just simply add to that to say that on the program that I work on, we see that reflected all the time in terms of people contacting us, and you know, the main reason that they don't feel like they can, you know, access the care they need, or the reason they're seeking help from us, or sometimes a very important reason for them to choose whatever choice they're choosing with their pregnancy outcome, has to do with the factors that they are considering, like that are like that, right? That are about, you know, what are my rights if I choose to parent? What are my rights if I choose not to? What, you know, and actually just not having that sense of autonomy and not having that sense of actual choice, because they're experiencing either personal coercion in their own lives in terms of reproductive coercion, or they're experiencing that at a systemic level, in terms of coercion by policy that is not going to either allow them to parent or allow them to access an abortion in a safe way. And so I think these things really, like, you've both really just outlined some like very specific examples that illustrate, that can be transferred almost in a way to illustrate how they impact people in any kind of a context. So I'm grateful to talk about that. And then I just think, I mean, it should be obvious, I think, to all of us, but I will just add in there that, of course, the racism that people experience when they actually interface with the health system is a major barrier, as it is. Just to even be willing to pick up the phone to make an appointment, or to seek care, or to call our service, like any of that, you know, is a risk for someone who experiences racism. And so that's just a major piece to to all of this, and including, you know, someone being perhaps delaying care or not being able to access care because they've been turned away, or because they've been turned away in the past, or their family members had been turned away in the past, or they are afraid of being deported by making a phone call and asking for help. So, you know, all of these things are also so interconnected, and just wanted to name that piece about like the actual interface with the health system, because it is a very real piece. And actually, I might add on one thing to that, which is just that, that also comes in the form of language barriers or being mistreated when you're at your actual appointment. If you have managed to get that far, if you were not turned away when someone told you how much it was going to cost you, or, you weren't afraid of, being arrested for something that had happened in your life, or that you were, intoxicated or high when you made the contact with the system, like all of these things, right? So if you're not afraid, if you're like, okay, I'm going to make this phone call, or I've moved past those barriers and actually have that appointment, we do see that there are all sorts of barriers that exist within that system too. So I don't want to take up too much time now, but I'll just quickly name that there are aspects of the actual like obtaining an abortion that can be full of barriers themselves, in terms of, someone needing to have access to communication devices to hear back, to receive a phone call back about your appointment, or to be able to book a second one. So you travel somewhere and then you need to go for a counseling appointment first, even if you are sure about your appointment, sure about your decision, and then needing to return for another appointment that might not even be booked until sometime later. So at this point, your gestation is higher. So there's a whole number of different things, and I could go on and on about them, but I think those things are all really like sort of the minutia of the expression of these larger topics that we're talking about.
Oops. Thank you so very much. I love listening to all of you. And I think, Coral, your comment around sort of the connections that we're seeing, that it really all is connected, and it's sort of systems that reinforce these barriers and gaps.
I think Evelyn might have had a follow-up to that.
Oh, I'm so sorry.
Did you? No. Okay, sorry.
No.
I'm not the moderator.
Actually, yeah, you're very intuitive, because I did, but then I'm like, no, I'm gonna let it go. No, I just listening to you, I just also thought about with migrant workers are placed in such impossible situations, because they cannot grow their families or bring their families. It just makes me think about choice, like in who has the choice and who's coerced in their lives. So with migrant workers, if they become pregnant, most of the times, if their employer finds out, they will be sent home. And then in order for them to qualify to come to Canada, they have to have children. So they're just placed in a really a very strange position where they're basically just used as commodities, and then they can't even be with their families, or don't have any support with family planning whatsoever. And so there's so many myths that we have to bust and challenge in terms of Canada, so that way we can actually address, these myths that sometimes put us in spells as if everything's fine here, and these spells work really well across the mainstream. So I think our conversations are about, demystifying so many ideas about Canada that basically don't really exist for many communities, racialized communities, marginalized communities. This is what marginalization looks like.
Yes, absolutely. Thank you so much, Evelyn. And yeah, I really see it all coming together. And I think this sort of leads well into our next question. Today, and as we were writing the submission and in your sections, like we see that there's so many connections between it all. So this is specifically for you, Mary and Evelyn, who both contributed sections sort of relevant to your areas of expertise, but making note that it would, of course, be false to think of people experiencing homelessness or migrants as two sort of separate, mutually exclusive groups, and also that there's just sort of so much shared challenges there. So can you speak a little bit to those shared challenges and experiences we see coming up, beginning perhaps with Evelyn?
There's a lot, but the ones that jumped at me this morning mostly than any others are like this instability of life, and how that instability doesn't allow for a continuity of care, or how that or you can't really have stable networks of support because of instability. So again, even though migrant workers come with all their paperwork in hand, they're still in a very unstable context, right? And so these are the structures that make their lives unstable. It's not because of them individually, it's because of a whole range of systems. And then something that irks me so much is this invisibility as well. So the things that, we don't know or see in the mainstream about homelessness, houselessness, and then also with migrant workers, it's very interesting or tragic to see who is actually seen and by whose voices, there's always voices speaking, but whose voices are actually being acknowledged, right? And so I see that too, this invisibility that is also very structural and systematic of how certain peoples are just silenced, but by whom? Because they're speaking. So I saw like instability and invisibility to be one of the commonalities across these populations, although there are of course many more.
Yeah, and thank you so much for acknowledging that these two groups of folks often are, we're talking about sometimes the same people, people who are experiencing precarious immigration status for lots of reasons, often find themselves trying to seek support in the emergency shelter system. What stands out to me, I think, is while there's lots of similarities in terms of the barriers to the practicalities that prevent the lack of access to safe, timely, and respectful abortion care, things like not having a phone, things like not having a doctor, things like not having the proper documents. I really appreciated the photo that Evelyn showed because, while in the document we talk about a lack of privacy as a barrier, it's also surveillance as a barrier. And, for migrant workers who are living in, very restrictive environments, that kind of mirrors where, people who are experiencing homelessness are living in shelters or other spaces where they are also under surveillance. And so not only not having privacy to have the procedure, but having your own decisions sort of being surveyed and not having that privacy in so many different ways, I think prevents people from accessing the care that they need or the care that they desire. And then, of course, not having a phone and not having access to resources to travel, all of those things just complicate what's already a very difficult system to navigate.
Yeah, I think it's interesting that we see in very different ways that sort of these jurisdictional issues, like that who is able to access or worthy of care in a given context, it very much depends on colonial borders. And I think also I love your reflections on sort of instability as this key thing. And I think so often we think of this instability that maybe is shared between, in many cases, migrants and people experiencing homelessness as innate or inherent to a situation, and sort of turning it back and recognizing that as a policy choice in both cases is important. And then just, like really honing in on that element of surveillance and criminalization as a really often unsurmountable barrier. Coral, do you have any last reflections on what Mary or Evelyn brought forward?
I'm really struck by the language, like the phrases that are coming up kind of over and over again between the four of us are, or I think well summed up by what you just said, Lona, about people being worthy of care or not. And I think that really speaks to those policy decisions that are being made that essentially treat a large number of people as disposable and not worthy of support or care. And I think I also want to point out that I think there is that instability is such an important word for us to use while we're talking about this. And I'm really grateful to have that word surface, because what it makes me think about is how that can be true across populations, right? Like that can be true in different ways, not in the ways that we've been mostly focusing on today, but the people being at risk to not being able to access abortion care is an issue across many different communities. And I think it also speaks to the instability of the system that is providing the care. Like it is not, there are these gaps that already exist in it, so that even if you already access a significant amount of privilege, it is still challenging. And so I just kind of want to highlight that piece too, that like we need to have systems that support everyone. And that's what we're all here talking about. And if we did, then we would actually be supporting everyone. And I think, there's all sorts of fields from, transportation planning to food system planning all over the place who will talk about how, if you actually, from an anti-oppressive perspective, think about how to serve the person who is the most vulnerable that you're thinking about, then that actually benefits everyone. So I just want to throw that piece in there too. Not that we should have to use that as the logic, but it's important, I think, to keep in mind what it is that what we're saying, right? Like we're talking about that disposability of people.
No, absolutely. And I think also that recognition of like this report sort of really hones in on two issues that we see, these like really intense access barriers. And it also focuses on abortion. Like there's a need to sort of limit our scope because of all of sort of the limitations of this type of reporting and time and capacity and the complicated nature of the world. But I think that links to our next question. And so like our submission focuses on abortion access. Most of these issues could be applied also to other areas of sexual and reproductive health and rights or health access in general. But we also see often that those who are most impacted by barriers to abortion access are also those who disproportionately face barriers to healthy and happy pregnancies and parenthood. So here I'd also recognize the leadership of Black and Indigenous and racialized women and trans and non-binary people in the development of the ethos of reproductive justice, which underlies this question especially, but I think we tried to sort of build into our submission to the degree that was possible within this sort of a report. But yeah, can you speak a little bit to this and sort of to that element of parallel control of sexuality, of reproduction and parenthood? Maybe beginning with you, Mary.
Sure. Yeah, absolutely. That's a complicated question. At YWCA Hamilton, we have started a program focusing on what we're calling it emergency reproductive care beds, but they're dedicated beds with wraparound support from a doula to try to provide a safe, stable place for people who are either pregnant and planning to carry to term or who are seeking a safe place to rest after an abortion. And, in doing this work, we're seeing firsthand the barriers that people are facing, right? The fears of child welfare involvement are so overpowering and so real in people's lives that it prevents people from even wanting to have an initial prenatal appointment with somebody. The fear of, having the child apprehended if people have decided that they want to carry to term is very real and prevents, I think, accessing healthcare. We also are really learning about the unique barriers for women who use substances during their pregnancy. At the Y, we have a safe consumption site, and we're explicit in our support of women who use drugs, particularly women who are using intravenously. And for folks who are using and pregnant, the stigma from healthcare providers is enough to prevent accessing prenatal care, coupled with the fear of child welfare involvement. And then again, lack of access to resources and living in conditions of such extreme poverty prevent, I think, people from having the ability to make choices around their pregnancy that promote health and promote their own well-being during that time. So, yeah, lots to think about, but those are just a few things that come to mind right away.
Thank you so very much. That's, yeah, absolutely important to keep in mind. And I think as that sort of forms sort of the background to our discussions where we're focusing on abortion access, but it is always sort of present and there. I'd pass it now to you, Evelyn.
Can you repeat and rephrase the question, please?
Yes, of course. So like, how do we see beyond just abortion access, these same barriers or different sort of parallel forms of control impacting particularly migrants? So people's sexuality or parenthood or pregnancy being policed or surveilled or?
The main word that comes to mind that I want to reinforce again is coercion. I see like the differences of like whose lives are valued, who has the right to have a family, who has the right to access care. And then I wanted to add in relation to systemic discrimination, which is very real. I know I've even experienced it, and I'm a professor and all of that, but navigating the healthcare system is, I've experienced racism for sure. And so when it comes to migrant workers, they experience racism, but also, this idea among some of the healthcare providers, including those on the front lines, those that are gatekeepers that say, no, we're closed. And I'm like, well, actually, I have to explain all the work that I had to do along with the migrant worker to even get to a particular clinic. That they experience also xenophobia, and that idea that who are they, like they have no right, or they're taking away jobs, or they have no right to this healthcare system because Canadian taxpayers pay for that. So, and of course, migrant workers pay into all of these taxes, including EI, that they don't even have access to, and they've contributed, if we do the math, like millions of dollars over the years. So then there's that layer too, xenophobia and ignorance among frontline healthcare providers. And then in our work too is that there's a high turnover rate many times with people working in the community sector, in the nonprofit sector. There's precarity there too. And so then we lose connections or contact with people within the system that are our allies. And then we constantly have to, like, our work is grassroots, right? And so a lot of the things that we get done are through like informal networks. And so those informal networks are easily broken. And so then we are left with struggling to see like where there are gaps in the system and how we can take advantage of some of those gaps through allies that can help us get the support for migrant workers that we need. So I see, that difficulty too. And I really think it's also important for us, like even as organizers and community support people, to give language to that as well, like the type of work that we do, because we're the ones that are in the middle of like where the state is not. We occupy those spaces, but it's very challenging to navigate all of that. But it also requires a lot of creativity, a lot of resourcefulness, and that's something that we don't give ourselves enough credit for. And I think it's important for us as community workers to share our strategies, of course, within the context of safety. So yeah, so that's what your question means to me. So then with migrant workers, there's a whole range of stigmas and oppressions that go along with them when they even show up to these clinics and to these health centers. Yeah.
Thank you so much. I think that's very important. And I also see, like, I think we could talk forever and I would love to, but yeah, there's so many sort of elements of family separation and parallels that we can apply in different cases, and around sort of this normative model of what is worthy or good parenthood. Coral, you're welcome to offer any reflections or build on what Mary and Evelyn have put forward, but I'd also ask if you could just speak a little bit from sort of a perspective of bodily autonomy on these connections and how abortion and safe and healthy and happy pregnancy and parenthood and sexuality go hand in hand.
One thing that I just want to share before I forget is something that my colleague shared with me, which is that on our line, we are consistently seeing, like within our program that I was talking about, our fund, we consistently see about half of the people that we support are identifying themselves. So we're not actually, asking for the statistic, but this is, just self-disclosed. About half of those people are folks who are in some kind of uninsured status. So that can mean a number of different things. That could be that they don't have access to the proper ID that they would be required to have to fit into the clinic system or a healthcare system. That could be because they don't have that ID at all because of their migration status. And that could also be that they simply don't have a copy of it. They have lost it. They can't get help to get another one. They're in a different province and they're seeking care, et cetera. So I just wanted to share that, just kind of a little bit off topic, but just to kind of give everyone a bit of that context. And that, so that's about half that we see on a month-to-month basis. And more recently, we've seen actually up to 70%. So just to kind of like share some context with folks around numbers, that like this, we're not talking about like, you know, just a couple people over here happen, although of course those people matter, but like also just to really bring some weight into it, I wanted to share that, that those are numbers that come from only our program, not you know, however else anyone might be accessing support. And then, yeah, back to how bodily autonomy is connected to this, and, you know, healthy parenting and safe parenting choices, you know, the ability to make the choice for safe parenting or safe abortion. I want us just to spend a little moment thinking about this idea of like good parenting, and in particular good mothering, because we are talking about you know, a societal phenomenon of policies that are created through colonialism and through white supremacy, and that is also deeply connected to how patriarchal systems function. And so I just think about like the ideas that we have that are in many different aspects of our culture and our societies, that police people in all of these different moments of when they're seeking care. And so people's idea of what a good mother is or is not, and how an individual who is indeed the person who is enacting the policies can actually think about an individual person or a group of people, I think has a really serious impact on the decision making that happens around these rights. And so I think that when we have this kind of these concepts of like, you know, people need to be a so-called good mother, and then there's a list of things that a good mother does and a good mother doesn't, that these things then really, they just immediately rule out anyone who has to travel away from their family to work in another country, who is using IV drugs on a regular basis, who it's just instantly you're crossing people off that list of what is good and what is acceptable. And so right away, those folks are not actually invited into their own conversation about what their own body sovereignty is. Like we have a society of people who are policing one another and our own selves about whether or not we deserve to even make these choices. So when we talk about like my body, my choice, and this kind of like, you know, language that gets used around abortion care and reproductive care, it's very, very easy to forget, I think, the philosophies that underpin how some of these decisions get made on an individual basis, but then, you know, creating to stigma, creating to the environments that people are in. And so I just think about like the need to shift those ideas, right? The need to stop blaming moms who use drugs. Like that needs to not be a thing that our culture does. And it is something that we are doing all the time. And so what those shifts look like can also be addressed through, you know, like I would say autonomy supporting policy, autonomy supporting drug policy, right? Like how are these systems all interacting to really encourage us to undo some of that underpinning. So it might be a little bit like highfalutin philosophy there, but I just think those things have such an influence on what people perceive that they're allowed to do, and then also what people are actually allowed to do. So when they say, this is the choice I want to make, and their care provider or, you know, their employer or their family member, anyone around them, basically interacts with the choice that a person is making, it's going to be impacted by all of those influences. Yeah, Evelyn.
Yeah, you just also made me think about the hypocrisy within our society. You know, when Mother's Day comes around, it's, you know, it's like, let's celebrate, you know, parenting through the mother, like motherhood, but then there's no affordable housing, lack of, you know, daycare support. So it's like, who can be a mother? And then with the migrant women, they cannot bring their children with them, right? So, and migrant workers in general, they have to work here on their own. So we celebrate certain narratives, but then behind these celebrations, there's nothing concrete. And that impacts those who are already marginalized in different aspects of their lives. So I always like to challenge, those mainstream narratives as well, and celebrations that are just so superficial. Because if we really wanted to celebrate parenthood, then we would see that in policy, and we obviously don't. Yeah.
And so because of that, people have to make these decisions about their reproductive health without any context or any support web, right? There's, they're making that without childcare, without, in circumstances of poverty, in circumstances of policing. Those decisions then are mediated immediately. Yeah, thank you for naming that.
Thank you all. This has been so very interesting. I think I'm also sort of, without having much time to talk about it, struck by how things overlap in the sense of specifically thinking about pregnancy and parenthood or motherhood and drug use, and how we see, like, there's a constant stigmatization, but how we see stigma and criminalization being applied in a way that is so deeply and profoundly conditioned by racism and classism, and not exerted equally either. I'd love to keep talking more and more and more with all of you, but I think we need to turn a little bit back to our submission, and I'd also like to sort of turn our gaze forward a bit towards addressing these challenges and visioning beyond them. And I'd also invite everyone to please put your questions in the Q&A. We'll have some time towards the end, but we can touch base on other things after if there's things that we either don't have time or want to think a little bit about before we respond. And so we're going to have a look at our recommendations from the report to the UPR. So the recommendations for action that we wish to see made from other states to Canada. And I think what's interesting about these recommendations as we formulated them isn't so much them individually. So we won't be giving you sort of an itemized list. You can see that in the report if you're interested, but we'll talk a little bit more generally about sort of the pillars today. And so the first pillar is a strengthened and well-resourced commitment to SRHR, sexual and reproductive health and rights. So some of this is around things like funding, Health Canada's Sexual and Reproductive Health Fund, which funds some of our access line work and which we need to see made permanent. But it's also really about sort of this broader favorable environment and working with provinces to safeguard access. So specifically through things, positive measures towards that, like federal health transfers explicitly tied to the expansion of SRHR services, and also the establishment of clear benchmarks for the availability and accessibility of abortion care. The second pillar is around dismantling barriers and enhancing barriers to low barrier care. So I think a really, really important piece that I'd acknowledge the weight of within this is status for all. So within our report, we echo the demands of the Migrant Rights Network for no exclusions and uncapped regularization program that includes all undocumented people and their families. And we'll pop some more context around this in the chat. And we'd also encourage you to sort of look into it and support upcoming actions. We also recommend federal health transfers, specifically targeting the provision of care for those who are uninsured. But I would note that this is in addition and not an alternative to status for all. And of course, comprehensive sexuality education in those schools, which we know is effective in combating myths and disinformation, which is a major access barrier. I see there's a hand raised, but I'm not sure if I can figure out how to attend to it. But if you do have a question that you'd like to see addressed right away, you're also welcome to pop it in the chat. And then also we included a recommendation around supports for federal patients. So situating transportation and accommodations for people who are incarcerated, for instance, as an important piece of access and a really direct federal responsibility. Although recognizing that the government of Canada is accountable for human rights implementation in all jurisdictions. And then last but not least, we also recommend nurturing a broader framework for equity in healthcare access. So some of this speaks to funding for community-based organizations, not necessarily focused on sexual or reproductive health or rights. But importantly, we also recommend that Canada consider and address access barriers in the development and implementation of broader laws and policies, especially where they could inhibit access for people facing marginalization. And so I think this recommendation around sort of policy coherence is really key. It kind of hugs all of the other recommendations, as their effectiveness is limited if we don't see sort of all policies through a lens of how they impact access to abortion and other health services. And so we can pop to the next slide and make note that, like, ultimately our goal within bringing forward these recommendations is that they be made from other states to Canada and that they are then accepted by Canada. But that alone really isn't enough. We need to see them implemented. And what we see is that Canada really is lagging behind in terms of processes around civil society engagement and human rights monitoring and implementation. So it's absolutely crucial that Canada improves really, really drastically on this. And demonstrates commitment to these sort of broader global norms and standards. We've also seen very, very vocal interest from the federal government in protecting and upholding sexual and reproductive rights over the last little while, especially sort of after the overturning of Roe v. Wade in the States. That's excellent. We want to see this support be vocalized, and we celebrate that. But we also affirm that these rights can't be fulfilled without the fulfillment of other rights, including those related to housing and migration. And then I think it's important also that all of these recommendations, everything that we're putting forward, all of the analysis, be understood and implemented through a broader lens, and that this really necessitates a framework that recognizes the role of marginalization in conditioning access and takes clear and sustained action to address this in alignment with the Truth and Reconciliation Committee calls to action. And so that's sort of where we're at with the report. You are very welcome to access it and have a deeper look if you'd like any more detail. And we'll also have sort of some fact sheets and other resources coming out in the next months. But I'd like to bring it now back to our panelists and ask that you sort of begin wrapping up any final reflections that you have. We have, let's see, we have about 2 to 3 minutes each, if that works, ideally 2. But you're welcome to share whatever you wish. And I'd specifically invite you to share sort of just a brief vision for progress on these issues or what you dream of beyond the challenges. And the floor is open to you, so you can jump in where you'd like. Or I can tell you. Okay, Mary.
Thank you. Yeah, I mean, that's a hard question. It's important to keep a vision for a better future, you know, front and center, but it's difficult to do so when we are just reflecting on all the complexities that we heard today around how just deeply complicated these issues are. You know, for me, when I think about what needs to happen, I think abortion needs to be demystified. It is healthcare. It is a form of healthcare. There needs to be conversations happening about supporting people to access abortion care in all, you know, across health and social services, and not just in and by organizations who are explicitly, you know, reproductive justice organizations. I think, you know, having more pathways to low barrier care that can exist maybe outside of health systems, or just like a more community-based low barrier pathway to accessing abortion care. And I think, you know, and as we talked about today, in addition to abortion care, I think contraceptive care is critical, and that barriers that we talked about today, you know, could also exist when we think about people who have access to contraception and those who don't, and more supports for people who are choosing to parent, but will have barriers to doing so. I mean, we are focused particularly around people who are pregnant and using substances, and we can see the ways the systems are stacked up against them. So I think, yeah, it's just some final thoughts there, but lots to think about after today.
Yes, thank you. And these can be very abstract dreams. You don't have to actually solve it all. I'll pass it to Evelyn, and thank you so much for that, Mary.
Ooh, thank you for the permission to dream, because I think I think that, you know, over the years, our minds have been more colonized. So we have to decolonize our minds and really push ourselves to dream with our communities. And as an organizer, I wanted to say that I know really clearly I'm not naive about how we write up reports and have policy recommendations, and all of a sudden, you know, oh, you know, like if since we did the research, you know, there all these policy recommendations are going to be followed, right? I know it doesn't work that way, and I know that also as a researcher, you can have a huge sample size of people. So doing quantitative research with qualitative research and combine that, you know, you can present everything, all these stories. So, but then it doesn't mean that any level of government is actually going to respond the way that we want them to respond. So I really feel that we can't give up on organizing and developing capacity among our own communities and reinforcing what's already working, what migrant workers, for instance, are already doing, and making sure that they do that they are in safety, and then when it comes to that they're safe and that their well-being is front and center, while at the same time not giving up and not letting the state off the hook, the state in the way that it is organized around different levels of government. That's what I mean about the state. And also I want us to like think about how this lack of sovereignty of our bodies is a form of colonization on the body itself, and it's a form of bordering, and so like all these policies have a direct impact on bodies. And the last thing I wanted to say about status, when we talk about status, when I started working with migrant workers back in 2001, the first thing that myself and other members of Justicia for Migrant Workers, we realized that what was crucial here was status. And when we say status, we're saying that they should have the right to permanent residency, which will give them more leverage over, you know, in relation to their employer, that right now their employers have complete control, right? And so all these calls to status over the last few years that have gained a lot of steam, which is really good, they've only benefited still a certain group of people, and migrant workers, again, they've been left out. There was a pilot project last year, and some of the Caribbean workers couldn't even apply because their level, like the English that was required was advanced English, and there was a whole range of issues and obstacles. And forget about, you know, Spanish speaking or Cachiquel speaking workers, indigenous workers that, no, they didn't go to private schools in rural Guatemala to learn English, right? So again, they were excluded. And almost every single week, I can tell you that migrant workers from across Canada and back in Mexico and Guatemala ask me like how they can apply for permanent residency and actually stay in Canada and bring their families. And I would want policymakers, politicians to respond to them, right? And so, and these are some migrant workers that ask me, have been working here for 20 years. So it's completely unacceptable. So again, I wonder, you know, after so long of doing this work, why is it that migrant workers can be so easily dismissed, right? And for me, the only way that I see that is because of racism. So racism is alive and well, and of course it has all these expressions, and racism and connected to a whole range of other systems of power, such as gender, sexuality, and so forth. So it's important for us to give language to this and to make sure that we expand, you know, the healthcare, because right now that's like one of the last few things within the government that is also being attacked, healthcare. And then we need to expand it and be on the front lines to make sure that that one day we truly have universal healthcare.
Thank you so much, Evelyn. Coral?
Evelyn was speaking earlier about myths and like them. And I think for me, one of the things that I dream of is that we can look at this myth of Canada as a concept, and what we think it is, what we think it means. And I think I also, another thing Evelyn said was that we're under these spells. And I think my dream really is that we can see those spells and come out from under them and create new ones and different ones, that create a world where everyone has what they need, and where what we need is also interconnected with what the land needs, and where we start to remember that kind of as people, because I really believe that from wherever we are in the world, there's an older history of knowledge of what it means to not live like the way we are now. And so I think we can come out from under that. And then I think from kind of a more, a more specific way of talking about it is really like, okay, what is it that people are asking for? What is needed? What are communities saying that they need? And just making that happen. And part of coming out of under that spell is to not say, oh, but it doesn't, we don't know how to fund it, or, oh, but that's not the rule, or the rules told us this, or the law says that. Like, no, my dream is that we say, okay, in part of coming out and from under that spell that Evelyn so clearly talked about is actually enacting the things that communities are saying when they are organizing, and they're saying these are the things that we need, that what we need to be able to do. If we are not part of that community, is to say yes, and how can I support that? And if we are part of that community, that we are doing our best to take care of ourselves while we move forward with whatever those things are that we've articulated.
Thank you so very much. I think throughout the webinar, not just in this moment, but I feel like I've heard sort of a common goal or a common dream beyond the challenges, which I think is sort of around, a world where everybody has access to all of the things they need, but also this means not living in fear of criminalization or deportation or incarceration or stigmatization or violence or surveillance and so on. And this has been such a really, truly very interesting and special conversation, and I feel very grateful to have been a part of it. Thank you all so very much. I think now we'll turn it to the audience, and we have about 10 minutes or so for questions. I have a few here. We'll get through sort of those that we can, but we can also follow up. And we'll also send out sort of a little package with a few things in the next week or two, and can address any of these there. But if you have any questions, we can also put my email in the chat. And if anyone else wants to put their email, you're also welcome to, with no pressure. If anyone would like to get in touch directly or has sort of more pointed questions. But we'll begin with this one. So, are there currently programs in place that provide a safe place for people to recover from all types of surgical reproductive health care, like the one Mary touched on? And I'd pass that over. It's not my area of expertise, but my inclination would be that it's sort of very patchwork and dependent on the context. Maybe, I don't know, Mary or Coral, if you'd want to jump in there.
So all I know that in Hamilton, where we're located there, that we are the only option providing that. My understanding is that if other programs do exist across the country, they're limited, but I actually don't know of any that do exist, but maybe Coral might know through her work on the action line.
So I would say that there's no official program that supports people post-abortion. That would be kind of my line. Like, I would be like, Mary, yes, of course, in Hamilton, but kind of the way that I think about it is that, like, this is not a funded program that is specifically to help people accessing abortion care. And maybe we need that in this part of the world. And we don't, we don't have that, as far as I'm aware, except for programs that, like the one you're involved in, Mary, are like, yes, of course, we do that in this particular way. Surgical abortion is one where, it depends on the type of procedure that folks get. And so in terms of what kind of recovery is needed, and as well as what kind of anesthetic is used, and therefore impacting the type of recovery. So I mean, I guess I would just really say that, like, that is a major gap in our system, is that people are discharged from care and then they need to go back to taking care of their kids, or where they, a place where they don't live, or where they do live, or to their job, or, they're sort of expected to be well immediately. And not need that time. And I think that our culture expects that. Like, I think the kind of overall society expects people to have to hide abortions and not actually have a place to go. That all being said, there are absolutely support services. So our fund supports people who have traveled for abortion care and are going back to a hotel room, for example, that has been organized through our fund so that they can stay there while they recover before they return to the home community. So it's not that there are no, I guess when I say there are no programs, I'm talking about how this isn't a service that is sort of included in the abortion care package in Canada. And until someone is supporting someone needing an abortion or accessing one themselves, they might not actually see what's actually encompassed as part of that system and that process. So that's kind of why I name it that way. But there are certainly support systems that exist in different communities. Most of them are volunteer run. Some of them are funded, and some of them are, as you'd mentioned, Mary, like connected to another program or, you know, as part of another service that's offered. And I think there are some possible thoughts about it in the chat as well. But just I'll leave someone else to take a look at that. But there isn't kind of like a place where people go. I would say that they need to be connected to a service or a provider or some kind of other support system. And like I say, it's often volunteer run for those times that are after surgical abortion.
Can I just say that with the migrant workers that I work with, they have to pretend that they didn't go anywhere or do anything, because they're worried about losing their jobs and getting sent back home by their employer because of that very real fear and the very real coercion and policing that they experience. So they have to just go to work. And so having that time to recover would be ideal, but it doesn't happen, and obviously in many contexts.
Thank you all so much.
And can I add to that,
Of course.
Lona? Is that okay? Just that I was just seeing in the chat that Birthmark, which is an excellent service in the Greater Toronto area, does provide support for sure post-abortion, and then someone else had noted that there are nothing that's government approved. So that's kind of what I mean when I say programs, like in terms of it being official, where anyone could access it after any abortion service. That's much more difficult to find.
Thank you all. This is really, really interesting and helpful. I think this question sort of leads into some of what you were saying, Evelyn. It's around if you can speak to potential threats of immigration enforcement or deportation risks for people accessing abortion, and if service providers have a duty to report someone with undocumented status or to not, if they're paying out of pocket for services. And if you don't have sort of the details on this, because it gets a little technical, this is something we can look into more deeply. And
I don't have all the details, and it depends on, you know, where workers are going to, because every community is very different and you don't know who's going to be at the front desk, so to speak. But now there's even more fear with the government taking back funding, for instance, in Ontario for uninsured people. So, and even immigrants who are new to the country, they don't want to be sick, right? So even like a lot of permanent settlement stream immigrants, you know, like they try to also police their health in so many ways. So I know that a lot of women who are undocumented that want to continue to have, like, that want to continue their pregnancy, they're struggling in finding prenatal care. And I saw that Emily said that there's a lot of community folks doing this work, which is awesome. But migrant workers are not always connected to community, again, because of that instability and the borders between themselves and the mainstream community, especially with other folks that do not speak their language. And I can't speak to the other part, but I know that we can't expect all healthcare professionals. Of course, there's really awesome ones that are all about access, but not everybody's like that, right? So, so it's very frightening for undocumented peoples to have to navigate and be subjected to perhaps being deported or being like rejected from their immigration claim, whether it's humanitarian or asylum seeking peoples. Like it's a huge concern. They don't feel safe.
Thank you, Evelyn. And I'd also just add, like in some jurisdictions, I know there were extended provisions around care for uninsured people during COVID. So service providers were mandated to provide care, and those have largely been repealed. So we are really seeing sort of this intensified wave of people being denied abortion care in those contexts. We have so many great questions and we're not going to be able to get to them all. I'll maybe just close and direct this to Coral, if that's all right, on threats posed by crisis pregnancy centers or anti-abortion sort of fake clinics who may advertise their services to vulnerable or marginalized people.
Sorry, I didn't quite get I got the topic, but I didn't get the part of the question. Could you repeat it?
Yeah, so I guess like the threat of misinformation and disinformation largely, but specifically crisis. Yeah,
absolutely. So I mean, great things to be talking about as we're talking about all of these pieces. We have a crisis of misinformation and disinformation happening right now, and that is making its way into very dangerous policy, especially if we look into what's happening in the United States around trans and gender affirming care and the just general right to exist as a trans person in that part of the world. So we're seeing these things ramping up in a major way, and certainly north of that border, we're not immune to that either. So it's absolutely connected to abortion care, because we're immediately talking again about bodily autonomy and personal decision making about your own body and your own rights. And so we look at those things as connected issues. Actually, Action Canada has recently published some pieces about the connections here. So if folks are interested in seeing some writing on that, please do check out our website for that. And in terms of crisis pregnancy centers, so we know that crisis pregnancy centers there are more of them in number than there are abortion services in the country. And so they are in all sorts of places, sometimes actually built next to abortion clinics or near hospitals in communities, sort of posing almost at times as if they are clinics as well, offering pregnancy tests and sometimes ultrasounds, appearing as if they are clinicians, and can be a very, very tricky way that people are faced with a barrier to abortion because they immediately aren't even sure what services that they're getting, right? Or they're told, oh no, abortions don't happen in our town, or they don't happen in this part of the world, these kinds of things. So it's a very significant barrier, and it's a very significant piece to all of the puzzle. And of course, this is, even more intensified when people are facing barriers and they run into misinformation or disinformation, whether that's online or in their community in some way, and or if they access care or try to seek support at a place like a crisis pregnancy center, and then are basically either denied care or coerced in some form. And that may be enough to become a barrier immediately just there. So we see those pieces as coming up fairly often. And of course, those two are connected to one another, right? We see the crisis pregnancy centers providing mis and disinformation, and increasingly with more skillful ways to sort of hide their motives as well.
Thank you so much, Coral. And thank you so much to all of you. This hour and a half has really flown by, and I'd love to keep talking. Maybe we'll do sort of a formal close. And if anyone does want to stick around for a few minutes longer, I have no personal opposition to that, but no expectation, of course, that anyone does. There's lots of questions that we'll get to, and we can sort of send a little response and a follow-up. Please do feel free to get in touch if you want to discuss anything further. And yeah, just a massive thank you also to the interpreters and all of my colleagues who ran all the things behind the scenes, and especially to you, all of the panelists. I really am so grateful and feel so full. Very, 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 yeah, huge thank you.